Good afternoon, everybody. Thank you for joining us today on this latest installment of our Atom webinars. We are going to, like normal, we're going to give just a couple minutes for folks to get out of the last meeting and get on over here to this one, and then we're going to jump right in. But glad to have you all with us today. All right, we're at 2:02, 2:03, so we'll go ahead and get started and let people trickle in as we go through a few housekeeping items here. So just again, thank you all for joining us. My name is Eric Christensen. I'm the VP of marketing here with Adam and with PayerWatch, and just want to welcome you all to this webinar. Today, we're going to be going over kind of basics of DRG downgrades, how to what's changed recently, and kind of how to win that battle today in 2025. There's call-in information. If you do have any audio issues, this is the number to call. You can download this in the download section, but if you do have to dial in, here's the call-in number and the access code. And then I do want to point out just a couple things in GoToWebinar. At the top right of your screen, you'll see these icons here. So we would love you to submit questions kind of throughout the webinar. We'll answer some kind of if we can as we're going, but if not, we're going to address them at the end given time, and if we can't get to them at the end, we're going to make sure that we send out answers to all the questions post webinar. And then also the little download material icon there, make sure you go there and download the PowerPoint from today. And if you do have any audio issues, just go to that settings icon there and you can adjust your audio settings. I do want to also bring your attention to the bottom right of your screen. You'll see a captions option. So if you do want to pull up kind of live captions, you can toggle that on. A little plug for next month's webinar. That one, which will have CEUs attached to it, will be dealing with successfully defending outpatient auth denials. That's going to be on 10/18, 2 p.m. Eastern time, like normal.
With a guest speaker.
If you are,
have to be looking at Reggie, myself, or Carla. So we're very excited.
Yes.
The Atom board advisory board has expanded significantly, and with that, we have a number of subject matter experts who are eager to bring you their experience and opinions as relates to the world that we all occupy and work in on a day in, day out basis. So as we move into fall, you're going to see a lot of new faces, a lot of different content that we haven't touched previously, and that talk will be the first of those to follow.
If you are new to Atom, just a little bit about who we are. We're just really the only organization in healthcare that is kind of brings together as a community everybody that deals with denials and audits and appeals. We're here to be a support, a place for timely news and training and education. So if you're not a part of Atom, we encourage you to go and join today. You can go to atom.org and find the join link. I do want to also point out that we are right on the cusp of launching a brand new website. So for all of our Atom members out there, stay tuned. We're going to be launching that soon. We're very close. I don't want to say a date yet, but we're getting very close to having that wrapped up. So looking forward to that big time. Just a quick word about PayerWatch, who sponsored today's webinar. PayerWatch supports hospitals as well in this space of denials and audits and appeals, and they do that primarily through technology and appeal support, the two arms of who they are. Software to accelerate and simplify your whole appeal process for every type of denial and third-party audit that you might be getting. And then Appeal Masters is their services arm, where they will provide as needed appeal support to back up your own internal teams. Very big fans of an in-house approach to appeals, but know that needs some support from time to time very often. So want to be able to support that in any way. So check out pairwatch.com if you have any needs that they might be able to help you with. I do have to read this verbatim, so bear with me here. The Association for Healthcare Denial and Appeal Management publishes and distributes materials on its website that are created by our members or invited industry subject matter experts for the benefit of all ADAM members. ADAM does not certify the accuracy or authority of these materials. These materials are distributed and presented as research information to be used by ADAM members in conjunction with other research deemed necessary in the exercise of ADAM members' independent professional judgment. ADAM claims no liability in relation to reliance on the content of these materials. The views expressed in the materials are the views of the materials authors and do not necessarily represent the views of ADAM. Any references are provided for informational purposes only and do not constitute endorsement of any such resources. And there are no conflicts of interest to declare for any individual in a position to control the content of this presentation. All right. Today's presenters are going to be Dr. Kendall Smith, Chief Medical Officer and Chief Physician Advisor at PayerWatch, as well as Reggie Allen, who's the Chief Clinical Business Operations at PayerWatch as well. And you can certainly read more about their backgrounds. We won't go through all of that. A quick overview of the learning objectives. So giving you the ability to distinguish between coding versus clinical validation versus dual denials and kind of pick the right evidence for each one. The use of 2024 and 2025 CMS Medicare Advantage rules and the February 2024 CMS FAQ in your appeal language. And then the ability to apply sepsis and ARF, AKI, quick checks, and direct rebuttal structure that wins. So I'm going to turn it over to those who know a lot more about that than I do and let them in the training. Dr. Smith?
Great, thanks. So Reggie and I are going to be doing this jointly. I'm going to start initially, and Reggie's going to go over some details of how to identify these particular types of cases. He's in the trenches a lot more than I am, and very familiar with how these things tend to masquerade and pop up. His guidance and experience, I think, is invaluable in that regard. So today's webinar is going to be focused on folks that are in the trenches handling clinical validation appeals. These are something that started out, I think, right before COVID, really, and have now grown to such a point that they make up the vast majority of appeals and audits that PayerWatch is seeing. And I would imagine that most of the people attending today at the ADAM webinar are probably involved in. We're not going to cover coding edits. We're going to focus on whether the diagnosis is clinically real and defensible for the dates of service. And the dates of service will come up in just a bit as to that significance. Why is this significant to you at this point in time? As I said, these things have grown exponentially. The money at risk has become really eye-popping, and it's really started to jeopardize the financial health of a lot of hospitals and healthcare systems across the U.S. If these things aren't appropriately challenged and kept in check, the amount of revenue that can be recovered by auditors and plans is quite significant. Plans, especially Medicare Advantage, and you have to remember that year over year, Medicare Advantage is adding more and more enrollees. Although this year, a number of plans have taken steps to disenroll some of their patients to improve profitability. But over the last 2 years, MA plans have continued to invalidate diagnoses using what they purport to say are internal criteria, but I think we all are aware of seems to stink of automation. And we're going to get into some litigation that's come out over the past year that addresses that allegation specifically. In recognition of this, beginning in 2024, Medicare started to tighten guardrails around these types of audits and around Medicare Advantage plans in general. Specifically, Medicare Advantage must mirror traditional Medicare for basic benefits. And when Medicare isn't fully established on a particular benefit, process, procedure, any internal criteria that the MA plan comes up with has to be publicly posted and evidence-based. I'll talk about the publicly posted issue in a wee bit here. Algorithms can assist, but they cannot replace clinician review or invent new criteria. We're going to look at some litigation around this very issue, which is quite telling. What payers are not allowed to do. They can't use undisclosed or moving targets. They can't auto-deny with a tool alone, as we'll see that seems to be happening, at least the allegations of it, or substitute proprietary thresholds when Medicare standards otherwise exist. So they have to defer to Medicare. If they're relying on internal criteria, they can't just obliquely say it's our own criteria and not explain explicitly what they're using. You're entitled to the web link, the URL, the version, and the date as applied to the date of service.
Kendall?
Yes.
Kendall, you need to ask, your slides are not moving. You need to tell.
I haven't moved forward yet. So this is just an overview, Reggie, but thanks.
Okay.
I was just setting the field for what we're going to get into basically. So
Gotcha.
as far as focusing on clinical validation appeals, best practice as we're going to explore here is to ask for the rule of decision up front, what evidence they relied on. We'll talk about tying every assertion to patient-specific facts, including vitals, therapies, labs, imaging, and then using diagnosis-specific proof sets like SOFA scores, acute respiratory failure, AKI for KDIGO, and other nationally recognized standards for specific diagnoses. What not to do, and then we'll get into the slide deck today, is don't argue coding rules to solve a clinical dispute. These are not coding validations. They are not looking at the appropriateness of coding. These are clinical disputes. And as a result, do not cite coding clinics as clinical criteria. Coding clinics were meant for coding guidelines. They were never meant for clinical disputes. Curate your literature. We'll talk a bit about that and connect the dots to the actual chart evidence and date of service. So don't do a literature dump of a quick Google search and pasting in 20 articles that seem related around the topic. You need to provide actual evidence as relates to the dispute. We'll go over clinical validation versus coding versus dual edits, and then we're going to talk about how you can insert the 2024-2025 CMS final rule and updates into your letters, and some quick takeaway cut and pastes. Before we get into this at all, I got to have a quick conversation about contracts. So the ability to argue one of these things is going to be dependent on you not being tied to a contract that gives deference to the insurer to make definitions. And all too often, we work with clients who, when we start to look at their contracts, there's language in there that the hospital agrees to abide by the provider manual or the provider terms. And we see all too often that provider manuals, provider terms are updated with provider-specific definitions. United first did this in 2019 when they came out and said, we're going to do away with traditional SIRS, and we're only going to pay and code for sepsis according to the SOFA criteria. Insurers are now taking that one step further, using modified SOFA criteria, which is a discussion in and of itself. And if we have time, we'll talk about that at the end. If you want to move on to the next slide, Eric, we'll get into the meat of things here and get things going. So I talked about the guardrails that Medicare put up in 2024, 2025. We've got about 4 slides here to talk about them, and the relevant URLs are in blue. These will be accessible with the downloaded slide set today. came out last year. Medicare Advantage, as I alluded to earlier, has to mirror traditional Medicare. Traditional Medicare covers something and has specific language around it. MA plans have to mirror that. They can't go off in the left field and come up with their own coverage criteria. So if a traditional Medicare patient was going to receive that service, et cetera, or there's a specific Medicare definition around it, the MA plans must honor that. Internal criteria can only be developed when Medicare is silent or not fully established, and that is contained in Part 422 of the Code of Federal Regulations, which is contained in that link. So the next slide, Eric. This, I think, is significant. All too often, we see clinical validation audits come across, and they may make a broad allegation, such as, based on our review, this diagnosis is not substantiated. That is something that needs to be challenged. And when used, internal coverage criteria must be publicly accessible. It can't be hidden behind a paywall on the payer's website. A year or two ago, United, when they purchased Interqual, moved to Interqual guidelines. And I have to say, it took me a lot of digging to get into the public-facing version of Interqual through UHC. It's there. It's not out in broad daylight. And so the definition, in my opinion, of publicly accessible, sometimes the insurers are running fast and free with that. They certainly have to be based on current evidence guidelines. The American College of Cardiology standards, for example, American Society of Gastroenterology. And again, this is reiterated by the federal government. Next slide, Eric. 2024, 2 points came out. And as I alluded to, the issue of not behind a paywall or on request only is the big one. The government has said that public posting means just that. It has to be widely accessible to enrollees and providers. I have had some difficulties searching and finding those. Reggie, you've got some experience with that. What has your experience been there?
Same there. We work very closely to try to find out exactly what they're using, and we again encourage everybody to, when we're writing it, they come back and say that they're denying it. We kind of need to know what it is that they used, what the basis was for it.
Yeah, you can really spend time digging sometimes to get to the root of where these things came from. We are in a world awash with AI. I think there's a lot of anxiety and fear of missing out. Certainly, insurance companies seem to be far ahead of providers in their willingness to use AI to deny claims. The federal government has said that algorithms and artificial intelligence can assist but cannot replace required criteria. And they specifically say that adverse decisions require individualized clinical review. That's the expectation. The reality that I'm seeing is that a lot of these denials come across with the exact same language in them, denial after denial after denial. And if a human were engaged in that, I would expect some variation. We'll look at some litigation later in the talk that alleges this is not happening, that there are AI programs and algorithms just running amok, denying things, automatically downcoding them, and then sending them back to hospitals to have to appeal. And there's a link to the American Hospital Association website as to where these 2 guardrails come from. Next slide. The final rule that came out earlier this year, transparency and evidence basis for any criteria remain. There were many additional utilization management and AI proposals were discussed, but they were not comprehensively finalized. So at the end of the day, human in the loop has to exist. The takeaway is that the evidence has to be publicly searchable and available. This is not changing as of the 2025 rulemaking for 2026. I think in all reality, as we move into 2027, 2028, we may see this language shift significantly, but that's speculation at this point. Next slide, Art.
So I think what's most important here is how are we recognizing these DRG and clinical validations, which is something on the operational side that we see a lot of. And so it's really important that the clinicians link themselves with the people in the revenue cycle, because one of the first ways they tend to come is through a letter for additional documentation. What's interesting is as we do our dive with working with our clients, we see that some of them had these records requested, but because when the revenue cycle team reviewed the account and it was at zero, they didn't recognize that what they were in the midst of was an audit. And so there is always a time frame with those letters that you have to get the medical record. If you don't get the additional records to the payer, what's going to happen is they actually going to come and take the money back. The second way we're seeing it is that is reason code 252 on the EOB will be out there, and it's asking for additional records or documentation. If that's overlooked by the people that are doing that in the business office, you probably have an audit going on that's either DRG or clinical validation that you may not be aware of. The third thing that's the most important one is what we call was the claim status 22 that you see on the EOB, which claim status 22 means that the claim is being retracted. Usually when they do that, they will send back a remitted advice, and either three things are going to be on it. It's going to be zero payment. And all of these cases, I guess the danger that we're seeing is a lot of these cases, as you guys know, are cases that have already been closed. So they're actually, these may come back, 6 months, 1 year, all based on the insurance laws of your own state and how many years they have to be able to do lookbacks. You'll get a claim status of 22, which means it was retracted. There'll be a new RA that'll show up. It'll either have zero payment on it, or it'll have a lower payment than the amount that you actually received originally. And then some of the claims are really good because they will have a DRG on there that you have to go back and see what the original one was. And we're talking about going back 2 or 3 years. And now you see a new DRG. And then sometimes they just get retracted and there is no reason. So I guess my takeaway here for everyone here is that there are a lot of hospitals, as Dr. Smith said, that are bleeding. They don't realize that they have DRG and clinical validations because they disregard either the additional letter. They don't recognize that 252 is actually really an audit needing more records, or they see that they got a lower payment, but they don't go back to see what the original RA was, or that there's a change in DRG, and you're not going to know that unless you can go back and pull the old claim. And of course, if there's an unknown reason, those are we've got a couple peers that fall in that group, and some of you are aware of those. Then we need to start working with them to understand you took the money back. Why? Because there's no change in DRG we can see, and you didn't provide a lower payment. Next slide, Eric.
So the key thing I think to differentiate when you have these in your work queue is, are you dealing with a coding issue or a clinical validation denial? Medicare's own language is that the purpose of DRG validation is to ensure that what was billed is basically supported by the record, by the beneficiary's medical record. In their scope of work, it said reviewers shall validate principal, secondary diagnoses, and procedures affecting or potentially affecting the DRG. And this was what gave rise to the current industry of clinical validation. Relevant diagnoses are those that affect DRG assignment, which is why these focus on CCs and MCCs. The contractor shall exclude diagnoses relating to an earlier episode having no bearing on the current hospital stay. So this is really the scope of work and what led to the current clinical validation audit environment. Next slide. DRG denials are denials based on coding guidelines and are generally best appealed using coding guidelines, coding rules, coding clinics. An appeal using a clinical rationale for a coding denial is unlikely to be successful. An appeal that proves that the diagnosis procedure that is being questioned was correctly coded and followed applicable coding guides should be successful. We are not getting into coding disputes today. We are getting into did the chart documentation substantiate the diagnosis that was arrived at. Coders can't interpret things. They have to code from the record. Clinical validation audits really exist to argue that the diagnosis, that the work that was done, that the information that came back did not support the code that was generated. So they're going back a level into the chart. Next slide, Eric. Example of a coding denial: acute kidney injury denied because there was no treatment. So remember, major criteria, MEAT, for coding. There has to be evidence that something was measured, evaluated, assessed, or treated for it to be coded. That's what you're going to see if you're dealing with a coding denial. Best handed over to a coder to determine whether appropriate coding rules were followed. Next slide. Clinical validation denials, as I said, are denials based on clinical factors, generally best appealed using clinical criteria. And I think the key here is from evidence-based medical sources. So the tighter your medical evidence, the more relevant it is, the better chance you are going to have to succeed on an internal appeal. Generally, when we're writing these, we're writing them with an eye to getting them to arbitration, mediation, or dispute resolution, realizing that a lot of these will just be upheld at the initial level of appeal. So by inserting evidence-based medical sources into that, you can influence the finder of fact at external review, arbitration, or mediation if your hospital chooses to go to that point. There is a little bit of a space for some coding info in there, which we'll get into later. Next slide. So clinical validation denials, the big ones we see, what are they? The big five: encephalopathy, AKI, respiratory failure, malnutrition, sepsis. Did I leave anything off, Reggie? No, that's a big five.
That's your big five.
That's a big five. And they're the big five because, surprise, 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 they're all major comorbidities. So when we're talking about an MCC, you're talking about a secondary diagnosis that's going to change the degree of difficulty on a DRG substantially. Your risk of mortality, expected 30-day readmission rates are significantly higher when you have an MCC. Realistically, this is a money game. And when you look at a typical diagnosis with an MCC versus one that doesn't have an MCC, you're often dealing with $4,000 to $8,000, sometimes $10,000 difference, depending on the procedure that was undertaken. So the MCC as a degree of difficulty has enormous impact if it's successfully recovered or recouped by a payer on the financial health of the hospital. These are thousands of dollars per denial. These are not nickel and dime ED level of care downgrades. These are substantial, and if they come after a group of patients with encephalopathy, audit 100, deny 100, and you don't respond to them, your system may be out millions of dollars in the blink of an eye. Next slide, if you would. I hate this, and I rant and I rave about this because, to me, as a clinician, a clinical validation denial is saying that I did not diagnose the patient appropriately. In my medical judgment at the bedside, providing active care to that treatment, that my medical opinion that that patient had encephalopathy, that that patient was septic, that that patient had acute kidney injury or acute kidney failure. The auditor is coming along, no patient relationship, and saying that we're undiagnosing your patient from those conditions. And I've gone so far in some of the more egregious clinical validation denials that I've seen to issue complaints to the Board of Medicine in the respective state for that facility against the auditors, alleging that they've been practicing medicine If you look at the legal definitions and the laws around the practice of medicine, only a physician, clinician, nurse practitioner, physician assistant acting under a physician's license, or in some states independently, is capable of diagnosing a patient with a disease and providing treatment. If you have an auditor, and most of these people will not provide their names or credentials, it's blinded quite often as to who's behind the scenes, coming in and saying your patient does not have this. They are undiagnosing somebody. They are, just as involved in the treatment, I think, as the physician who actually provided the original treatment. And that, to me, is encroaching more and more on the practice of medicine. I encourage folks, when you see these that are completely ridiculous and you can't get the names of the auditors that are involved, to file complaints with the Board of Medicine, Attorney General, State Department of Insurance, alleging that this is encroaching on the practice of medicine under state law. Practice of medicine is defined under individual state laws. It's not defined at the federal level. So you'd have to look at your individual state practice rules and regulations to make that determination for your own instance. Next slide. Dual denials. These things are a headache, and they're such a headache. Reggie, you want to jump in on this one? Because I've talked way too long.
No, that's fine. So basically, when we see them, they're really a combination of both clinical criteria, and they also have a coding component to it. We have a special group of staff. Most of them are all certified and clinical documentation, and they typically a lot of them have some coding experience, and so they write these, and sometimes they're so complicated until what we actually do is get the coders write the piece out of the coding side, and then we let the clinicians justify the clinical criteria for the patient. They can be very successfully done, but you're going to need both sources in order to do it. So the documentation that we will also leave, as Kendall will share at the very end, is both the coding to justify with the coding guidance in it, as well the peer review information that we get from the clinical literature.
Yeah, these things can be a hot mess and a pain in the backside to untangle. When I get involved in them, typically I'm on Teams or on the phone talking to a coder, trying to pick things apart. As Reggie said, clinicians will write and address the clinical part, and then we will send it over to the coder to deal with the coding allegations. These are really time consuming and complex, and make sure you don't miss them and you're able to identify them for what they are. And you don't just approach it as a one size fits all, or this is just a big clinical validation, because you'll miss the coding. And quite often they are going after both of them, because you may have more than one MCC on the chart. You may have sepsis and encephalopathy. You may see an allegation that there was not sufficient clinical criteria to support a diagnosis of sepsis, and encephalopathy was not treated, and therefore did not rise to the level of a codable condition. And that's the type of language that you're looking for. Hopefully you have a letter with these, because if you don't, you're in the dark, and you are entitled, and the payers are required to provide written reviews to you with these to be able to rebut them. Next slide. Eric, can you get next slide?
I did. On my end, it's showing.
Yeah, he's already. It's just an example of dual. You can go to the next one.
Oh, okay. Yeah, sorry, I missed it. I had a TIA, which probably is a CC. Let's focus on the top. So yeah, along the lines of what I was saying, and this is part and parcel of what was going on. Go on to the next slide, if you would, Eric. Who's best focused to write clinical validation appeals? I think about anyone that's got a good understanding of clinical medicine. We have coders that have a good sense of clinical bedside medicine. A lot of them were nurses before they became coders. Clinicians that have some understanding of coding rules and guidelines, which I think is beneficial when you're getting into some of the nitty gritty of these things. Clinical documentation specialists, often great resources to address these, because CDI specialists straddle both coding and the clinical world together. They're often working directly with the coding department and then translating the medical record back into queries for clinicians. So if I had to pick one and said I could only have one type of person doing these, my personal preference would be to have a clinical documentation specialist. Not to say the other ones aren't capable of it, but if you limited me to one, I think CDI specialists probably are going to have the best experience across both landscapes. Regardless of who writes the clinical validation appeals, please make sure that the reasons for the denial are addressed thoroughly. These things should not be rushed out. You have to look at the argument being made by the auditor and refute it on a line-by-line basis, specifically bringing forward clinical information in the chart. Quite often when I look at these things, I end up doing what I call connecting dots. So the physician may not have explicitly linked lab findings, radiology reports into their notes, but if an auditor wants to open a chart and argue about it, then I am going to go through all pages of the medical record, bring forth laboratory evidence, venous blood gases. I almost said Venus Williams, but completely wrong sport today. Venous blood gases, arterial blood gases, oxygen saturations, respiratory therapy notes, etc., to support a diagnosis of respiratory failure. So feel free to color outside the lines and pull forward any clinical facts that you think are going to support your arguments. Next slide. Go ahead. Never ever trust what the payer is telling you. Time and time again, we find errors in what's being alluded to. I may look at citations that they use in support of their argument and find out that they post-dated the date of service. So they may point to a journal article that was released in 2025 for a date of service in 2023, for example. Look at every reason that they have, and I try to push back at every reason that is not correct. Next slide, Eric. Direct rebuttals. I think this is self-explanatory. Acme Insurance Company says that sepsis 3 criteria were not met. Simple, by going through the chart and looking at the SOFA score, hopefully it's been explicitly documented, but we can often pull this information together out of labs, subspecialty notes, and recreate a SOFA score. We can prove that they were actually met. So if it says something did not happen and you can pull the evidence together to show that it did, should be a slam dunk. Next slide. You really need to painstakingly show the auditor where you got this information. It's not enough to make broad statements that the medical record showed that the patient was confused, that they got better after 2 or 3 days and they returned to baseline. You need to go through and cite chapter and verse where you're finding this. Page 16 of the medical record, the ICU doctor noted that the patient's baseline mental status was significantly different than noted on the first night of the hospitalization. Or by day 3, the neurologist puts in a note in the chart that says patient's mental status has returned to baseline. Key for a definition of encephalopathy, but include the hospital day and the page number in the chart where you're finding this. If there's a query, hopefully that's part of the permanent medical record and you can reference it. We really encourage bringing those forward. Any thoughts to that, Reggie?
No, I think we'll be able to demonstrate it when we do the example in the appeal.
Sure.
Pass that in. Okay,
so let's get ahead to that. You really need to go through at a painstaking level, as I said, go through the lab results. I love these things. To me, they're like scavenger hunts. And it's surprising the number of times you'll find significant laboratory abnormalities. I can't tell you how valuable triage nurse and ICU nurse notes are for getting granular information that physicians, nurse practitioners, physician assistants don't include in their notes. Great sources of information, especially vital signs, etc. Response to treatment, again, nursing notes are really beneficial for picking those sorts of things up. But at the end of the day, your appeal needs to demonstrate all of these things: why the diagnosis was made, including everything that substantiates it clinically. Quite often, I get the feeling that the auditor may not have the entire medical record. That may either be by design or by chance, but I get the feeling sometimes they're just looking at a few pages of the record because some of this stuff is so obvious. You would think if they were doing a fair audit, they would have at least taken the time to open the chart. I get the feeling that some of these things are being AI generated and sent back with no real effort to look at the record itself. Next slide. You don't have to be a coder to learn and apply this. So with the principal diagnosis, insert the definition of a principal diagnosis, which is the reason found after hospitalization for the bulk of the care provided to the patient. That's from a clinician's term. I'm not a coder. I don't represent myself as a coder, but that's my understanding as a clinician of what a principal diagnosis is. Why did the patient come into the hospital? As determined after some reasonable period of study. It may not be the exact complaint they hit the ED with. It may be something that pops up shortly after hospitalization. They may show up confused. Day one, they may become floridly septic on levofed in the ICU. Principal diagnosis isn't confusion. Principal diagnosis under that scenario would be sepsis because confusion was an early manifestation of sepsis. We talked about the MEAT, M-E-A-T algorithm or acronym. For secondary diagnosis, something has to be measured, evaluated, assessed, or treated. Basically, the hospital can't code something written in the chart unless something occurred around it. So if the hospital expended resources in terms of lab tests, nursing time, medications, ancillary studies in support of that diagnosis, then it becomes codable. If you're dealing with a newborn, and this is important because we do see a lot of newborn downgrades, there is an additional caveat that in cases of newborns, their secondary diagnosis could have an implication for future health needs. So kernicterus, patients born with hyperbilirubinemia that require UV therapy in the hospital, but monitoring for cognitive development, those sorts of things would qualify. Next slide, if you would. Clinical source documents, as I said, the big thing that we're seeing is that they use the latest, greatest article that came out, and they're looking at a chart that was 3 years old. You look at the publication timestamp, it was 2025. The record happened in 2022. Does the information actually apply to the reason for the denial? Time and time again, we've gotten into like Michelle Martin is a health law attorney who's done a number of these webinars with me. She's passed on a story over and over about blood loss anemia in a male patient. And I think the citing authority for that was an article in from American College of Gynecology or a similar publication. Obviously problematic because most males, biologic males, don't have gynecologists or obstetricians they're seeing. So that probably wouldn't apply to that experience. Key thing, if a payer is using clinical information from coding clinics, push back hard. Coding clinics are explicit that they are never meant to be used as a diagnostic tool. They are meant to be used as a coding tool only. Next slide. These are some takeaways that you can put into your appeals verbatim as you're dealing with these. So first one is an ask. Show me what you relied on in doing this and how this is publicly accessible per Title 42. Push back and say that if they can't do that, if this is based on non-public or undisclosed criteria, this lacks a valid standard and is a baseless appeal. So you can cut and paste these and take them away from you, and the source is below in the URL. Next, I think there's 4 or 5 of these we'll get into as takeaways, and Reggie will do a case here. The automation challenge, when you're getting a sense that something is being run by AI, and we see a lot of this, these do require individualized review. So you are entitled to demand who the clinician was and the posted criteria that they use beyond any tool output. And we'll talk briefly at the end about a lawsuit over this very, very issue. Next slide. As I said, coding clinics, not acceptable for clinical denials, only for coding things. And here is the takeaway from that. Coding clinic users may continue to use that information as clues, not for clinical criteria. Next slide. Again, reiterating what we've already talked about, I'll move forward in the interest of time so we can get through a case here and the lawsuits that have come out over the past year. Payers often will use their own criteria to deny. We're seeing some insurers that are now using what are called modified SOFA criteria, which take SOFA scores and then change them by removing the SOFA point for the infected organ, saying that respiratory dysfunction in a patient with pneumonia is expected because they have pneumonia. We're going to ignore the fact that they had respiratory dysfunction and hypoxia. It's not at all contemplated in the SOFA papers, and so they're coming up with their own unique ways of denying these. And I think you need to go back to your contract and say, what is covered under contract and how to use that. If you have a policy at the hospital level over certain diagnoses, such as Aiken criteria, rifle criteria, different criteria to define sepsis, sepsis 2, SOFA scores, etc. Send it in with your appeal. Point to that as a policy of the institution. It's not going to hurt you. It may help if you get to external review or an arbitrator or mediator, because it's showing a consensus by the institution. Couple quick cases. This is stuff that really, really I think is interesting. It's come out. There's 4 cases I'll go over, and I'll turn it over to Reggie for the last 10 minutes. One is a case against United Healthcare and Nava Health, which came out last year. This was allowed to go forward as a class action, allowed to proceed at a class level, where the allegation by the estate, patient died, was that United and Nava Health were using AI-driven terminations of post-acute care, so rehab care, SNF care, and Medicare Advantage cases. Courts are really taking a look at these algorithmic and AI determinations. Use this case as a basis to demand evidence of the clinician involved in making that review and the posted criteria. The link to the article is there. And this was in Minnesota against United Healthcare last 2023, I think it started, but it's been upheld and moving forward. Next case, if you would. Batch denials. So this was a big one against Cigna, called the PXDX case. This was a separate class action over automated rapid claim denials, and this survived its early motions to dismiss. This illustrated the judicial system's discomfort with lack of transparency, with opaque automation. So where the insurers are being dodgy and they won't let you know what criteria clinician reviewed the case, this is an interesting case to point to or argue about. The allegation I put forward there is that internal documents and former company executives revealed how Cigna doctors rejected patients without ever opening their files. Quote, "We literally click and submit," one former company doctor said, which is frightening. If you're a patient or you're a hospital, I don't think it's surprising to anybody on this call who's seeing these things day in and day out, but here it is coming to light now, as is the next case. This just came out in July of 2025. Advent Health sued the Kansas Blues, their Shawnee Mission Hospital, specifically over clinical validation audits, going over about 300 to 400 diagnoses and using, quote, proprietary and undisclosed criteria and recouping about $2 million. Specifically, the allegations made were that Blue Cross Blue Shield Kansas City's determinations to clinically invalidate physicians' diagnoses are purportedly based on criteria from various sources. Such criteria have never been disclosed to Advent Health in advance. Upon belief, the criteria are often based on outdated literature, irrelevant medical guidance, or publications that do not reflect an industry standard definition for medical diagnosis. And I think that thought that these do not reflect an industry standard definition for medical diagnosis is key to a lot of this. When we're looking at things like malnutrition and we see WHO criteria, World Health Organization criteria being cited, which were never meant to be used in the Western world in hospitalized, acutely ill patients, and the insurers relying on that as their evidence, very similar to what we're seeing here. So keep an eye on this. It was just filed a month ago, and it's got a while to run yet, but I think a lot will come out of this that will guide our work. Next slide. So I'm going to turn this over to you, Reggie, for our case.
Okay, so I think we need to slide down to some others. I will talk about a case that we have that has acute respiratory failure, which is the case that I chose to have a
Yeah.
discussion with you guys.
In the interest of, I'm trying to get through in the interest of time. So if you go over to the
Okay,
case, I'm going to go through Eric.
so Erica, let's just go down to like slide 43. We'll start this quick case study because there's only 2 slides after that. We did something
Yeah.
on AKI for you. Great.
Three
And so
slides
here,
through our takeaways to cut and paste for those
yes,
specific
correct,
diagnoses. I don't need to read them
correct.
to you, but when you get the slide set and you're dealing with any of those 3 or 4 specific clinical validation denials out of the big 5, those are arguments and criteria that you can cut and paste into your appeals, something to take away. So I'm not going to waste time on it. Now I'll shut up and turn it over to Reggie.
Okay, so actually, I really want to go over a case with you guys that we had, and we see a lot of this acute respiratory failure with hypoxia. This is a 91-year-old female that comes in with worsening dyspnea. She's weak. She doesn't even have enough energy to chew. She's very short of breath, and she is not typically on oxygen. So she shows up in the emergency room. She's tachycardic. Her PO2 is 89 on room air. She's tachypnic around 30, and so her pulse ox showed 88 on room air, and so obviously she's hypoxic and has abnormal oxygenation. Her lungs up from the physical exam. We always we first look at all of the clinical evidence of the patient. We looked also to see what the physician hears from physical exam, and he noticed that she's markedly diminished growth sounds in the right lung. Chest X-ray is done on her, and she has right side pleural effusion, and she's got some atelectasis. The physician documented that the patient is an acute respiratory failure with hypoxia. One of the things that I think is very important that Dr. Smith talked about is we always, and this where you see this 56 and 89, these are the page numbers where this information can be found. We always submit the medical record. We highlight the medical record in yellow, and any time that we are fighting any of these diagnoses, and then we put the page number in where the information can be found, highlighted in yellow, and make sure the medical record goes along with the patient. So they don't have to go hunt and peg. You don't really want to send a story out there, and as Dr. Smith said earlier, and then you're expecting them to go hunt and find it. It's probably not going to happen but you do get to point to them in the record, which is what they need, because we think sometimes, believe it or not, they're not reading the record. Next page. So we then get the justification written, and that is pretty much coming into letting them know that in the medical record, that it is very clear that the patient has met this clinical criteria with our oxygen. So once we identify all the elements, then we write the justification for it. We go in and say, okay, this patient has new oxygen requirements. We highlight that for them. Here's their O2 sat on room air. She's got atelectasis and diffuse consolidation. This patient was also had a thoracentesis done. They removed 750 cc's of fluid. She had greatly diminished breath sounds in her right lungs, which I already told you, and in essence, her right lung had failed. She's been placed on high flow oxygen. Her respiratory rate, the high flow oxygen, respiratory rate, and retractions are not required for a licensed practitioner for this diagnosis. However, we do, as we go through the record, we look for what if we have a PF ratio of less than 300. We also continue, and this is after they're initially seen in the ED. Are they still tachypnic? Is their O2 saturations still at less than 90%? On room air. We still look for labor breathing. I think Dr. Smith said something very important earlier. We go in the medical record because usually these patients still have labored breathing. They do have retractions and they're using accessory muscles. You usually find that in the nurse's notes. So we go in the nurse's notes. The nurse's notes will do a really good job of providing information to us more about what's going on respiratory wise with the patients. So don't be afraid to use in the medical record other things other than the physician's documentation when you need to tie the dots and connect everything to go together. So the reviewer is wrong because the reviewer came back and said that the patient's respiratory rate was not greater than 20, and as you see before, yes, it was much higher than that. I think it's around 40 something we showed on the other side of the page. We were able to find all of the other respiratory rates they had while they're in with nursing, highlight them, and our yellow highlighter, as well as provide the page numbers. Next slide. And then for the secondary diagnoses, although we know that we're really providing support just to the coding guide, but it's not necessary, as we talked about earlier. But to support the guidelines, we then take, because of it being a secondary code, and for additional codes, we take those 5 elements and we identify the patient met the clinical validation. And obviously, we're looking at the provider's documentation, clinically what's going on in the treatment plan. We identify any therapeutic treatments that are going on with the patients. O2 titration, the thoracentesis. We identify any diagnostic procedures that go along with the patient that they have that meet the criteria. And of course, a lot of it doesn't necessarily extend the stay, but if it does, we would specify that. And then any nursing care that's done, the close monitoring, as I said, looking at the vital signs, Dr. Smith brought that up. We then, for secondary diagnoses, we have this already in a section about template. We have templates for pretty much all of these most common diagnoses that our writers can actually just go in and put the information in. And then once we do that with the coding guidelines, and excuse me, to support it with the additional diagnoses, this is how we make sure we justify it. And next slide. The last thing, we also make sure always that, as Dr. Smith said, in our appeal templates, we have the resources and the references to justify, and then we highlight always. We will then, this looks pretty normal, but then what criteria the patient meets in the evidence guidelines, we bold that information in the evidence-based guidelines. So we're finding all the facts, then we write the justification of the story. If it's secondary diagnosis, we identify, take those 5 coding principles, and we justify there. Then we always close out with our sources and references, and we find the references that actually meets the patient's condition, that's evidence-based, and we bold that, highlight that, so it further justifies why the patient indeed has this particular diagnosis. Next slide. So, Dr. Smith, you can start the summary. I just have to add one thing to it. Maybe I'll start mine first, and I'll leave it up to him. I will challenge you to go back, as I talked about earlier, identifying these, and I would actually see, because when we're working with hospitals and they're really concerned, do we really have these? Did we miss them? They think they got all of them. We said, no. Why don't you dig in, get all of your claims that has that 22 on them, has a claim status of 22, and see exactly what happened to those claims? Did you guys ever get the notification on there that you indeed had an audit done and the money was actually taken back? Dr. Smith, you can finish up the other ones.
No,
That's my
I think
one
that the
challenge.
last point, because we've gone through all these other things, but I think number 7, as we hit the top of the hour, is probably the biggest takeaway I would ask for. As long as you're running from a master agreement that's 10 or 20 years old, I looked at one hospital in the Mid-South, their master operating agreement with one of the Blues dated from 1995, and that governed their relationship with a couple of amendments to it. You really need to have a clinician that is aware of the impact of clinical validation denials, sitting at the payer roundtable when it comes to contract negotiations. All too often, a 5, 10, 15% rate increase sounds great, but what we know is that money is going to be recouped on the back end through clinical validation denials, because it can be. So by tightening up your contracts through your institution, by taking your knowledge, your experience, your outcomes, hopefully at a payer specific level, and getting them to your managed care contracting team and talking about what this means, you can help to plug that leak a bit. Until contracts get really tightened up and address the clinical validation denials, this is forever going to be how payers continue to recoup what really is illusionary raises. So that 5 or 10% rate increase you think you're getting, you go out 12 or 18 months, you're probably going to find that you're upside down a few percent on that, and it wasn't nearly as robust as you thought until you're able to go in and do this. So we actually got done at the top of the hour, right to the second. I am going to stop there. Thank everybody for their time. As Eric announced, we have a new website starting. We're working on a certification program and credentialing program to get people certified and credentialed in writing denials, medical necessity, clinical validation, and coding, with an eye to that coming out towards the end of the year. A new and updated ADAM community and website. We've significantly expanded the advisory board to a number of outside industry experts from various large hospital systems and other vendors, and are relying on them to help guide the ADAM community going forward as far as content, education, and purpose. So I thank everybody for their time, and we'll see you in September with the next CE eligible webinar. Have a great day.
Thank you, everyone. We did have a lot of questions that came in. We will be sending those out since we did not have time to jump into them and answer them here. We will send those out to everybody who attended. So look forward to that email coming probably within the next week. Again, appreciate your time. Have a great rest of your day. Bye.